Well, good morning, everyone, and welcome. My name is Nancy Frank Wilson. I'm with the Minnesota Oral Health Coalition. Our numbers are growing, but we'll get started with just our housekeeping before our first presenters begin. This is our third and final day. This was a format that we just thought, hey, let's try it. So I'll be asking for your feedback to see if you liked it. But I want to thank all of our presenters so far and the presenters that we have this morning. We have no set break time, so if you need a break, run and do that. We are recording. All 3 days sessions will be on our YouTube channel. We'll make CEUs available. We'll also share materials. If you happen to get this link from someone or you're sharing it with someone, be sure and go on our homepage, click on registration. That way you'll make sure that you receive all the materials from the 3 days. I'd like to thank Delta Dental and Minnesota Foundation for making the Minnesota Oral Health Coalition possible and for being such a great partner to us and to just about everybody else in Minnesota Oral Health. I do appreciate it. And we'd love it if you would do an intro in the chat. Tell us your name, where you work. If you want to tell us what part of the state or the country you're in, that would be great. And anything else you want to share about yourself this morning. All right. How are we doing? Are we ready to go? Our first presenters? I'll have them introduce themselves, but the name of their presentation is Oral Health Impact Measure 201, Opportunities in Minnesota. Thanks, friends.
Thank you, Nancy. So I will share my screen. Can you see my screen? Okay, perfect. Yes, so thank you everyone for being here. I know we are in the last stretch of the wonderful conference. So today's session is in continuation of the seminar that we first had on Monday. So we are today we'll be doing the Oral Health Impact Measurement 201 and talking about opportunities in Minnesota in terms of using the Oral Health Impact Profile measurement instrument within the landscape of the dental public health in Minnesota. So we have 3 presenters today. I will go first. I know pretty much everyone here knows the other names on this presentation, but I will just take a brief minute to introduce myself. My name is Aparna Englishwar. I'm a researcher at the University of Minnesota School of Dentistry. I primarily work with Dr. John and Dana and Fonsuda, looking at and examining and researching dental patient-reported outcomes. So I'm excited for today, and hopefully we can get some good discussion going. Okay, sorry, I guess. So these are the objectives of today's session. In my part of the presentation, I will focus on and provide an applied example of how OHIP 5 can be used in combination with certain indicators of access, such as dental care utilization, to examine differences between those with and without an oral health impact. And as we go through the presentation, you will get to understand what I mean by those with and without an impact. My presentation will be followed by Prasida, Deb, and Dr. Helgeson, who will then talk more about their proposed medical dental integration projects and how they plan to use the OHIP 5 within those settings. So before I move ahead, I just want to do a brief recap of the Oral Health Impact Measurement 101 session for those who probably did not have the chance to attend the Monday seminar. My colleagues have very graciously allowed me to borrow this slide from Monday since they had such excellent visuals. So just as a brief recap, we do know, and the research has established, that basically in terms of oral health and oral health impact, there is essentially just 2 sides of it in terms of what the dentist observes in terms of objective impact and objective oral health, and then what the patient perceives and that we refer to as subjective oral health impact. And as we can see here, patient perceived outcomes or impact that is reported can be limitless, and there are numerable types of impact that the patient can perceive as a result of their oral health problems. And so Dr. John and colleagues looked at all of these patient perceived outcomes and distilled them and found that they were just 4 dimensions to these impact. So basically patients were perceiving pain, functional problems, appearance issues, any sort of psychological impact, mostly clumped on these 4 dimensions. So, which is what you can see on the right of this figure, which says this is the dimensions of oral health related quality of life. And what is the good thing about identifying these dimensions is that this also very well aligns with why patients come and seek dental care. In fact, in a large multinational study that again was conducted by Dr. John and colleagues, they found that reasons that patients primarily seek care at dental offices are mostly aligned with the 4 dimensions of oral health related quality of life. So this provides further support to the finding or to the evidence that there are 4 dimensions for oral health related quality of life, and these are the 4 dimensions on which patients perceive oral health impact. So in terms of what instrument we use to capture this, again, very briefly, as mentioned in Monday's seminar, the OHIP-5 is a questionnaire known as the Oral Health Impact Profile Questionnaire. It has 5 questions, and the slide here again shows you what the 5 questions are. And they have response options that range from very often to never. And so these 5 questions basically ask individuals about how much trouble, whether they have had any difficulty chewing any foods because of problems with their teeth, mouth, or dentures, whether they have any pain or they felt uncomfortable with the appearance. And as you can see, each of these questions align with the dimensions that were previously identified in terms of oral health related quality of life. While the figure here did show us a response scale of, a recall period of like the past 7 days, the advantage of using the OHIP-5 is that you can also alter that recall period. So you can ask patients or about how they felt in the past 7 days, but you can also use the same questions and modify the recall period and ask them that, oh, in the past 1 month, how have you had any problems with based on these 5 questions, or in the past 12 months? And this change in recall period has been shown to be pretty stable to the outcome as well. So what I'm trying to say is that it's pretty versatile in terms of applying this for different situations and also for different time periods. So my colleagues on Monday did provide this really nice graphic about how you would use the OHIP-5, or an example of how OHIP-5 could be used in different settings based on the information that's available. So here, the B stands for whether if you had baseline OHIP-5 information or not. The F stands for if you had follow-up baseline information or not. And the E is the change in that baseline versus follow-up. And this was the examples provided during Monday's session. So what I'd like to do is basically use the same sort of concept, but take it a step further and apply this to an example for general population. So in the example that I will be providing, our setting would be just a group of individuals in living in the community, or what we call as general population. And in addition to the OHIP, I will also be explaining how you can look at dental care access indicators or measures of access in combination with also measuring OHIP-5. So in terms of the example data that I will show you, the data does come from actual surveys that we did conduct. So in 2022, we conducted a survey to examine oral health impact, dental care access, and experiences with care among Minnesota state fairgoers. And while this survey was part of the larger study known as the Tutor Consequences Study, our particular interest was to look at the oral health impact as measured by OHIP 5, and then also ask the participants questions from the Dental Consumer Assessment of Healthcare Providers and Systems, known also as the dental CAPS. I'm sure many of you in the audience have heard of it and have probably used it. So this is just a glimpse of the questionnaire. So you're very familiar with these questions, but as I said, instead of asking them about 7 days, we asked them a recall period of 12 months. So the questions for OHIP were basically, how often have you had the following problems in the past 12 months? And the reason we wanted to use the recall period of 12 months is so that we wanted to be consistent with the recall period for the other questions about access to care and use of dental care. The numbers on top just tell you the scoring criteria. So very often, if a person responded as very often, we would score them as 4. Like was fairly often was 3, until we go to never, which is 0. So never means no impact, everything is good. So in terms of the other questions about dental care access and utilization, based on whether, since all of this was administered on an iPad, based on whether the person answered the previous questions as having any impact, that is, if they answered hardly ever, occasionally, fairly often, or very often, then they were asked certain questions. And if they answered never for any of the questions, then they were asked a slightly different set of questions. So these questions here assume that a person has answered something like, yes, I did have some problem with my oral health in the past 12 months. So if they did indicate that, then they would be asked these questions about, okay, so you said in the last 12 months you experienced some problems. Did you go to a dental clinic? If they say yes, okay, if you go to the dental clinic, what kinds of care did you receive? Did you receive a dental checkup or exams, or did you receive any type of therapeutic care? I've highlighted the first 2 options in pink, just so as to draw your attention to the fact that these 2, and you will see that subsequently in the next slides, were combined into one category for reporting purposes. And I will explain that further when we get to it. And so likewise, we would ask them other questions about if they didn't go to the clinic, why didn't they go to the clinic? What were the reasons for not being able to see the dentist? So these were the questions that we asked people who said that, yes, I did have some problem in the past 12 months. So now, if a person said that they did not have any problem in the past 12 months, that is, they reported never for all of the 5 questions, then we still ask them questions about their dental care with the idea that if they did not have any problems in the past 12 months, did they still want to go to the dentist? And so as you can see here, the questions are worded slightly differently. We asked them that, oh, in the past 12 months, you did not experience any problems, but did you still go to the dental clinic to prevent any sort of future problems? So drawing the preventive aspect to these questions. And the options in terms of response options were all the same, so that so the comparability between the groups, which allows the comparability between the 2 groups. Okay, so these are the total number of participants in our survey. So we had about 630 participants who filled out our survey. And this little graph here just shows you a distribution of their oral health impact scores. And as you can see, so the range for the oral health impact scores is 0 to 20. And as you can see, this red line basically indicates that about a little less than 200 patients said they had no problems with their oral health in the past 12 months. So basically they answered never for the 5 questions. And the other participants did show some impact, but mostly within like the 0 to 10 range, with very few showing severe impact, which would be about 15, and some moderate impact between 10 and 15 as the score. So what we did is that we divided this group into participants who said that they had some oral health problems. So that is if their score was greater than 0, and participants that said they did not have any oral health problems, so their score was 0. So as you can see, about 70% of our sample did say that they had some oral health problems. And so as we progress, I will show you more breakdowns about the dental care utilization patterns in this group. So in both the groups, that is with oral health problems or without oral health problems, this graph shows you the proportion that got care, that is, they went to a dentist to get care, versus those who did not get care. So in the group that had oral health problems, about 41% said that they, in the total number of participants, which is 630, 41% said that they got care because they had oral health problems. That is, they went and saw a dentist. Whereas 28% of the 630 said that they did not go see the dentist despite having oral health problems in the past year. So likewise, in the group that said they did not have any oral health problems, we still see about 25% saying that, oh yes, I did go see a dentist to prevent future problems. And on the flip side, 5% said that they did not go to the dentist. So we further looked at what types of care these people received in terms when they went to the dentist. And you can see DX stands for any sort of diagnostic or preventive services that they received. TX is for any therapeutic services that they received, such as extractions, oral surgery, or anything like that. And so this further gives you a nice little breakup of what kind of patterns you're seeing between people who have oral health problems and who seek care versus those who do not. And then lastly, with respect to the reasons as to why they did not go to the dentist, whether even if they had a problem or they did not have any oral health problems, we looked at the reasons, and we do see that insurance and cost definitely still is one of the greatest barriers to seeking care, especially among the group that does have oral health problems, wants to go to the dentist, but they cannot. So this further gives you some good context into, okay, so this is the group, why you're not seeking care, what is the real reason behind it? So now going back to the same setting and filling in the, I guess, the next steps for, say, suppose this population, we wanted to do something about this. And while this is just a general state fair population, if it was a community needs assessment and you did this and wanted to know that, okay, so this is the population I'm serving, what kind of issues they have, then based on this, we would probably think about maybe prioritizing interventions for the group that do have oral health problems but poor access to care. So in summary, I hope I was able to illustrate this, but OHIP-5 can be used in multiple settings at an individual and population level. My colleagues on Monday showed you the more of the clinical applications of OHIP-5 and the differences in scores, what you can do with differences in scores in terms of determining treatments for individual patients. But it also has applicability on a more population level, especially combining it with different measures of access or tailoring it to your program and population that you're serving. And lastly, information that we gathered from this sort of exercise can be used for planning purposes, for assessments of treatments, programs, and interventions. So the idea is to use OHIP-5 to make informed decision making, and also to get to understand the patient's point of view and what they perceive as the most important. Because whether a patient perceives or whether a person perceives that they have an oral health problem or not, that also dictates whether or not they think they would like to go see the dentist. So sometimes in limited resource settings, I think this would be a valuable approach to try to get this understanding, and then maybe based on this, determine what sort of resource allocations you would pursue. With that, I now pass the baton to Prashida. Thank you so much for listening to me, and I will save some. I suppose I'm assuming we can have questions in the end, or
Absolutely, people can put questions in the chat,
okay,
and at the end, I can manage those. Thank you.
Are you able to see my screen, Aparna and Deb? Okay, I'm going to minimize the screen here. Good morning, everyone. Thank you, Aparna, for that wonderful presentation. For those of you who may not know me, my name is Prashida Kanal. I serve as the State Oral Health Director, and today I'm here to talk about opportunities to use OHIP 5 in different community and clinical settings. But for that, I wanted to give you an overview of our recent grant, which is called Strengthening Geriatric Dental Workforce Using the Age-Friendly Health Systems. So this grant is funded by Health Resources and Services Administration. So I wanted to really thank the federal agency for supporting Minnesota to strengthen oral health workforce. So the objectives of my presentation is to bring a public health perspective to geriatric oral health inequities. If we want to understand why we are using OHIP 5 tool in our community settings, we need to first understand where these inequities are. I will also talk about the age-friendly health system. And finally, I'll get into the opportunities to utilize OHIP 5 tool in Minnesota in order to strengthen geriatric oral health workforce, for training of trainers, for community clinical linkages, for data and surveillance, and medical dental integration. So the HRSA funding to strengthen geriatric oral health workforce using the age-friendly health system comes at a critical time. Given the dramatic aging of the US population, the growing scientific interest in the impact of poor oral health on quality of life, the role of lifestyle strategies and cultural context in maintaining optimal oral health, and in increasing awareness of the significant health, social, and economic burdens associated with unpaid caregiving. As you can see on my slide, we all are already familiar with the graying of America. And in Minnesota too, we do see a demographic shift. Even though we tend to have more older adults in the state, they still continue to be an important aspect of our society. Data shows that 1 in 4 older adults in Minnesota continue to work. They volunteer at rates much higher than our national level. They are most likely of any age group to vote, so they continue to be one of the most important group of voters. And 74% of our older adults report helping or being helped by a neighbor in the past year, which technically shows that our older adults are still very active, and we want to make sure that we ensure the quality of life for them. So as we are talking about this demographic shift, we are also seeing another public health issue, right? The issue of unpaid caregiving, that it has been posing a lot of health, social, and economic burden on the state. So if you look at my slide, you see that 1 in 5 adults are caregivers at the national level. Caregiving could be lengthy and intense. 58% of caregivers at the national level tend to be women, and 20% of caregivers are actually older adults themselves, which is, again, very concerning in terms of strengthening our dental public health workforce. 4 in 5 of them manage household tasks for the person they are caring for, and over half assist with personal care as well. And 1 in 6 non-caregivers expect to become caregivers within the next 2 years. So if you look at Minnesota's data, this data comes from the CDC's website. So I was able to get it just yesterday. So it shows that 64% of, I think it's slightly more than 64% of Minnesota's older adults care to a friend or family member have cared for a family or a friend for last 6 months or more. So we do see that even older adults are actively involved in caring for other family members or friends. So unpaid or informal caregiving significantly affect population health in Minnesota, and current infrastructure is not sufficient to meet the growing needs. A public health approach is therefore absolutely necessary to lessen the burden and enhance the quality of life of caregivers and people they actually care for. Growing inequities in oral health of older adults is another big concern, and this was the open mouth assessment that we conducted in long-term care facilities. And the data was really concerning because 42% of our older adults living in long-term care facilities have a dental care need. 66% of them have partial tooth loss, and 25% of them have complete tooth loss. 3 in 10 older adults with fewer than 20 teeth do not even own dentures, but need them. But again, there are limitations to our open mouth assessment because we did not even get to assess the oral health status of our older adults who are living in their homes or with their family members, because this survey is geared towards institutionalized residents only. So what do we know already is that studies have shown an association between inflammation and periodontitis, or a severe form of gum disease, and Alzheimer's disease. And maintaining good oral health is particularly challenged for people with Alzheimer's disease and related dementia. There has been more studies conducted around dementia or Alzheimer's disease and oral health. So people with Alzheimer's disease or related dementia may forget how to practice oral health self-care or be even resistant to help. So therefore, caregivers play an important role in routine care of older people, specifically with memory loss, but may not even have that knowledge to support the people they care for. Medicare does not include dental benefits for older adults. So even though there is a known association between the inflammation of the gums and Alzheimer's disease, there isn't much we are doing because Medicare has not been able to provide the dental benefits for older adults. There are various barriers or social determinants of health related barriers to accessing care. What we see at the national level is about 96% of adults aged 65 years or older have had cavity. 1 in 5 adults aged 65 or older have untreated tooth decay. 3 in 5 of them have gum disease, and oral cancer is also more prevalent in people who are who are around like 63 years of age. This is the national data. So at Minnesota Department of Health, we absolutely realized the need for adequate integrated geriatric care within the underserved populations in rural dental professional shortage areas. So dental professional shortage areas are those areas, especially like over 50% of our counties are designated as areas where we have shortage of workforce, dental workforce, or we know that people are from low-income families, that they have barriers to care. So if you look at this, a couple of images I have here on my slide, the first map is it's a representation of older adults living in a household. So the darker green areas, all the green shaded areas here are areas where, or the counties where we see older adults are predominantly living. The county might have more older adults for a couple of reasons. One, it could be really age-friendly community, so more older adults are staying there or coming in as newer residents, or maybe it's a regular county, but younger people are going out of the community for employment, education, or other purposes. But then we were able to map to see where older adults are living. And then on the second image shows an overlay of the naturally occurring retirement community, the map where that shows the older adults living in household on top of the dental professional shortage areas. And the areas shaded in red clearly shows that there are many dental professional shortage areas where our older adults are predominantly living, and we have not been able to provide care to them. So that is the reason why at Department of Health, it was so important for us to explore a broader framework and be more innovative with our approach so we can strengthen our workforce and also really improve access to care, especially to our older adults living in these dental professional shortage areas. And because MDH has this unique opportunity to work with partners, we totally prioritize partnerships, and then through them, we try to come up with policy to improve community clinical linkages and establishment of dental homes. So as we live longer, we know that we need a health system that understands what makes our care unique as we age. The John A. Hartwood Foundation took one of the most important first steps towards the goal by coordinating an effort to develop age-friendly health system. So a system or a health system is called age-friendly when it's expertly designed to coordinate all of our care as we age while also making sure our personal needs, values, and preferences are at the heart of that care. So this is the model where you see 4 M's: what matters, medication, mentation, and mobility. And age-friendly health systems aim to follow an essential set of evidence-based practices, provide best care as possible, cause no harm to older adults, aligned with what exactly matters to older adults and the family caregivers. Also ensure older adults, their families and caregivers are satisfied with care, and improve the value of care for all, including the professionals who make that care possible. So how do age-friendly health systems achieve their goal, right? As you can see on my slide, they make health a team effort. So there's an example of Louis, who is an older adult, and the image shows how the primary care doctor manages his overall care. The nurse also helps in coordination of care. The pharmacist is answering questions about new medication. A neurologist is taking care of his stroke. A psychologist helps Louis, or this older adult, with to cope with depression. Occupational therapist helps with getting back to day-to-day activities. There is physical therapist. There is also social worker. And this model believes that older adults are the expert on what matters most to their health. The only limitation with this model is that there's no dental, public health, or dentistry, right? So with our effort, with the OHIP tool, what we are trying to do is actually put the mouth back in the body, so that eventually in the future, or at least for the Minnesota, we see a dental component in these infographics. So how are we going to do that? We are still going to come up with guidelines. There's a lot of work that needs to be done, but we're going to ask what matters to older adults and make sure that the outcomes of the care that we deliver is based on what matters most to the older adult. We will also review medication and decrease high-risk medications when possible. We would address mentation or mind by screening for dementia and depression, and treating or referring our older adults to specialists. We would also assess mobility and take action on a plan to move more and better. But there are gaps in our current dental system, right? Or in geriatric dentistry. Most of the times, our clinical assessment is very objective. It is essential, absolutely, yes. But it is also important that we, as professionals, value the personal characteristics, health behaviors, and broader social context and environmental factors that are independent of our older adults' health issues, because that really plays an important role in the oral health outcomes. Talk about no-shows, talk about medication compliance, right? Talk about older adults not being satisfied with their care. We really need to be not just objective, but also shift towards being subjective in our diagnosis and treatment planning, because right now we might be overlooking the older adult's perception of good health. I might provide a patient excellent denture, but is it comfortable to them? Is this something that they had preferred? Did they prefer something else? We don't know that, right? And are we also prioritizing the social cultural needs, which is the subjective findings? That is the limitation. We don't have any tool to do that. So that is when we got connected with Dr. Mike and his team and Aparna's research team. And now we have evidence that oral function, orofacial pain, orofacial appearance, and psychosocial impact can serve as a simple and clinically meaningful set of oral health-related quality of life dimensions, because several instruments items fit into these dimensions. So what I'm trying to tell here is that the presentation that Aparna did about OHIP 5 tool is a very short version of multiple OHIP tools that were out there. So as researchers or public health professionals, we didn't know which one to take for measuring the quality of life of our older adult, because there were so many versions. So what Dr. Mike did with his research team was he looked at all these tools out there and he said, okay, let's look at 5 questions, right? And then our role was to take it. So once we are able to take this OHIP tool, we are hoping that our treatment planning may be able to consider the characteristics of the epidemiological profile of the elderly population, not only in the terms of prevalent disease, but also socioeconomic conditions and their perceived health needs, which is going to be a big shift in how we deliver care. And we could also come up with a service delivery model and scale up community-based interventions for geriatric oral health, and how these interventions improve home care practices, increase referrals, and access to dental care within broader health system. So the way we are going to utilize OHIP 5 tool is we are going to implement it across all the HRSA grant activities. And we are going to work with University of Minnesota. We're going to work with Appletree Dental. We're also going to work with Minnesota Oral Health Coalition and then MDH Office of Rural Health and Primary Care. So Dr. Schumann has been leading the Minnesota North Star Geriatric Workforce Improvement Program, and he's going to help us convene Oral Health Advisory Committee, who's going to come up with guidelines for adapting the age-friendly health system. And then we are going to also offer continuing education for his mini residency in geriatric oral health. And there would also be scholarships and opportunities for dental teams, not just dentists or dental hygienists or dental therapists, but we want it to be more focused on the dental team. So there'll be scholarships and more opportunities there. School of Dentistry, Doctors Lopez, Self, and Quick are helping us put together a dental fellowship for postdoctoral candidates. So we will be able to use OHIP tool in their training. So our workforce knows how to use the tool. And the Appletree Dental is already working with Mayo Clinic, and I would leave it to Deb to talk more about the innovative data project that they would be absolutely using this tool and putting it into their system. I'm also thinking that if this project goes well, we might be able to take these questions and put it in our BRFIS survey, which is our behavioral risk factor surveillance system. It's a telephone survey. I don't know if some of you have already got some calls in the past, but we have an infrastructure set up at Department of Health to call randomly call people living in a household and ask them questions about their perceived health status. So there is a big opportunity for us to add this into the statewide data collection system, and we already did that with the peria question. So we had added multiple questions to assess the status of gum disease amongst our communities. There would also be opportunities for us to do a lot of training of trainers. And on the picture, you see our community health worker, Monisha Washington, who was able to deliver. She was trained by us, and later she trained around 75 unpaid caregivers who were caring for especially people with Alzheimer's disease and dementia. So we could do more of caregivers breakfast through community health workers. And this model has been also used at the national level as a case study. So it was published by Alzheimer's Association. So we hope to use the model that we were successful with in terms of using it across our dental professional team, where it could be like training our dental hygienists and dental therapists to work with patients living in long-term care facilities and really actually doing the community clinical linkages. And last but not the least, at the end, we all have envisioned, a dental home model. And we've been talking about how public health partners, community health centers, medical and health professionals, including community health workers, community-based dental programs can help us all establish a dental home. And then we will prioritize equity at the core of this dental home, because we want to really make sure that older adults have an opportunity to age in place. So as Minnesota is well on its way to a long-standing demographic shift that presents us with unprecedented opportunities and challenges related to growing older population, together we can build momentum and commitment necessary to ensure that Minnesota remains a vibrant, prosperous place to age and hopefully age in place. So with that, I would invite Deb to talk about her project.
Super, thank you. I'm excited to do this, and I need to share screen. And get back to the beginning. All right. Is everyone seeing the bouncing apple?
We
Yes.
are.
Yes.
TikTok. Good morning, everyone. And just a quick editorial comment. I'm worried that we're going to run out of time because I hope there's questions forming. So please do go ahead and put them in the chat. I won't see them. Nancy will monitor them, whatever. I just, we want to hear from you. So we're going to do that. So at any rate, I also just wanted to thank Nancy and Jane for putting on this conference and leading medical dental integration efforts here. I hope everyone knows that Minnesota is viewed as a national leader in so many ways in oral health. I mean, restorative expanded functions, our critical access dental provider program, collaborative dental hygiene practice, dental therapy, on and on. And so I feel like we've got more leading to do. So that's me. I'm the policy director at Appletree, and Dr. Helgeson asked that I present, but he promised to chime in. So I'm going to hold him to that, that he'll do that. Yesterday, Nicole shared a number of slides about Appletree and our background. So please play the presentation if you weren't able to see it, or get in touch with us. We love to talk about our work. Dare I say that we really do live our mission, and that we accomplish our vision in partnership with many of the people on this call and others. We've got 8 centers, and our patients come from all across the state. We are in about 80 towns and cities in a variety of settings that serve people, provide other services to people across the age span, lifespan. And we call our model community collaborative practice. I believe Nicole touched on this as well, but I want to note the interprofessional practice and the integrating dental care into health homes. We have a lot of medical dental experience. In my opinion, Appletree started that in the beginning by bringing dental care into the long-term care facilities that they served. And then here's a few other examples. The report on the side is from the Primary Care Collaborative, and they cite Appletree. They have principles for integrating care, and they cite Appletree as an exemplar under the continuous care model, and also mention us under the comprehensive and equitable and also the accessible principles. So we're into it. We're also very much into research, and I think because the founders decided we aren't using diagnostic codes in dentistry, let's make up ours and we'll use them. And so we have a very unique 36-year longitudinal database, and we are now using Open Dental, which gives us more flexibility to add in new and emerging things. The previous slide showed our tobacco cessation program, and this one today we're talking about the OHIP. And we're continuing our research capacity and analytic capacity in recent years by adding a number of other things: Power BI, practice by numbers, policy map, and even in the coming year, we're looking at some AI, using some artificial intelligence. So we are very excited about the OHIP 5, and we have been meeting with Dr. John and the D-Power team at the university for more than a year, exploring the different ways that we might utilize the OHIP. And you've already heard multiple times about the ease and the standardization and the ability to look across different places and collect the information in different places. So I see Appletree being excited in these 3 areas, which of course aren't, they're not separate. The research and the evidence-based care and the integration, all of that hopefully is feeding one another to have better and better systems of care. I included this, this is an international journal article from the D-Power team, and I just thought it made the point, like, what a concept, let's include the patient perspective in this. And also, if I'm honest with you, it's partly because I just needed an opportunity to say Mundgesundheit, which is the oral health in German. So at any rate, this is also from that article, and my partner colleagues would be better at explaining all the nuances, but I put it up just to quickly say, if you look at this, it really does show how getting this data together and translating it into evidence is what will lead to evidence-based care, but also it can lead us toward value-based care. And I think that's something that everyone wants to do. We want to spend wisely. And so this slide spoke to that, to me. And also shared earlier was that oral health really is a part of overall quality of life and health-related quality of life. So this one is from the ADA and the Dental Quality Alliance. Once again, Prashita touched on this as well, so I'll just keep zipping by, but we can do a fine treatment, but we need to understand the patient's perspective. And I like that the ADA is saying patient-reported health outcomes is an important thing. Nicole showed you that we have been working with the folks at Mayo on a grant where we're collaborating on things. And in this presentation that Dr. Grants has shown giving, he did tell the providers about the OHIP-5 and had a warm reception to the idea that it isn't as complex as looking in the mouth and trying to identify which teeth, but it still is a valid and validated way for them to get oral health information. So that ease of collection comes into medical dental integration as well. These are bullets. Prashita showed you a larger chart that had the different partners, and these are the data-related elements that Appletree will be working on. So we will be working with the Fairmont Center and across the different departments. And in this first year of planning, I am quite certain that we are going to be building in the OHIP-5 and other things, and then we'll be collecting and sharing that data with MDH. And all of this does feed, thank you for saying it so well, Prashita, all of this does feed to why does this matter? And it's because right now, a lot of people are not getting the care that they need. But if we develop a system where people are attached to a dental home, we can change that. And I just want to emphasize again that this is a partnership thing. We need to have good delivery systems, and it will involve our plan partners, the dental and medical providers, and all the other community partners. So our future vision is that we will meet that legislatively mandated target or exceed it by doing things differently, and that we will have a far better understanding of the patient's perspective in this. For the people that are not getting in, we don't know anything. We need to know more. And so this project is an opportunity, as well as several other things that we're doing with Dr. John and team. The state fair, we were involved with that, and at the county fairs, we have another one where we're reaching out to non-users to do that. And then just for the bigger population health approach to having a more equitable system and reducing all the health disparities. So I know I went quickly, but it's because I hope that we'll have some time for questions and so on. So thank you. And Dr. Helgeson, I thought you were a man of your word.
Thank you, Deb. You nailed it. So I'll just listen for any questions, and I'm happy to chime in as necessary.
Okay, so I know we have just a few minutes, but I wanted to start up the discussion with
Turn on my office lights.
with a poll for everyone.
The mic's office lights are on.
I've just placed a link in the chat, and if everyone could go to that, that would be great to see if. Can you see my screen?
Yes.
Okay, so you can either point your phone at this QR code, and that should take you to the same link to get to this question. And I would like to have everyone's responses. Okay, so we have one participant.
Can you go back to that QR code?
Oh, yes,
Yeah,
absolutely.
thanks.
There you go.
There we go.
Or link in the chat box too for those who would prefer that. Okay. Okay, I think that's about it. Wow, these numbers are really encouraging to see this, to see that about 80% of the audience here thinks that they would definitely see their practice, organization, or program using the OHIP-5. Related to this, I also have another question, I guess, since so many of you all mentioned that you could see yourself using this. This is a slightly different. So I have the link in the chat box, and I don't know if anyone here has used Jamboard or not. But if you go to the link there, and basically the question is, what are some of the challenges or barriers to implementing the OHIP-5 measurement within your settings? And so I have little post-it notes here, so please feel free to go and click on this post-it and start typing out your answers.
What a great tool.
Yes, I won't take credit for this. Deb told me about Jamboard.
Wow.
So Aparna, I think if people need to sign in, maybe they can just put it in
Oh,
the chat box.
sure,
and
yes,
you can just share your screen.
That is perfect. Can you see my screen?
Yes,
Yes.
Okay, so if
so people can just, yeah,
put
because
in the, yes, please, if you can put in the chat, that's fine too. I'll just put it up on Jamboard myself.
right. And if you are able to sign in, that's perfect.
Mhm. I think it says it appears to be view only. Oh, sorry. Let me see if now.
Aparna, do you want people to put something in the chat rather than work with the Jamboard if it's not working for them?
Yes, yes, you can either use the Jamboard directly, or you can put your responses in the chat and I will fill it out too.
Great.
That is fine as well. Training and capacity is one.
So Aparna, it is working. So people
Okay.
can just, yeah. So if people just click on the link.
Yes.
And then, but they have to choose the sticky note that's
Yes, you
on
have
your
to choose it.
side.
Oh,
And then
okay.
hit save, yeah. Mhm.
I did see siloed electronic health records in this.
Yeah, I think so Aparna, do you mind, yes, putting it as can you show the folks the little sticky note on the side so they can,
Oh, so it's here, sticky
Mhm.
note. And then you can type in your information and then say save.
and then save it.
Yes.
So we see educating providers on the importance of OHIP-5,
Mhm.
and lack of knowledge, which is again, training, right?
Yes. So workforce training and capacity is definitely a theme here. Siloed electronic records.
I love that. I think that's the key, right? Like silos of excellence we work in, and Epic is not talking to Open Dental or other software. So that's a good one.
Yes. So I think it's about time. So I guess we haven't, just in looking at the answers right now, I do see, I think the biggest theme here is about workforce training and capacity and okay, I do see another input here about resistance to change.
Mm-hmm. And Aparna, I think people can continue to put it in the chat, and Nancy can capture that for us, and we can.
Yes.
Yes, and I can say we can share it with everyone.
Yeah.
Yes,
Yeah.
at the end. So that's great. But thank
And
you.
for that matter, can you keep the link live for a while? So, if some people.
Yes,
Love that.
Company,
absolutely.
present company had to look up their Google password or whatever. It can be live for a while and then we can share it out with all the participants.
Yeah.
That sounds good.
And more questions can continue to come in chat, and we'll make
Yeah.
sure to respond to them as well.
And we save all the chat. So anything that someone wants to share, if you want to get in touch with anyone from this group, yeah, we will definitely share this. Well, we do unfortunately have to move on.
Yes, I'll stop my share. Thank you.
What a great team. Thank you so much. And if the presenters don't mind, you want to put your contact information in the chat, and people can get a hold of you later. I know this is a huge topic in terms of interest and the effect that it has and will have on dental health. So I look forward to doing more with you all, and I really hope that you can present again, and that we look for other opportunities, because it's big deal stuff. It's very important.
Thank you.
Thank you all very much. And if you want to, if anybody has questions, just put them in the chat and we'll make sure that that they get answered by this group. Thank you so much. Well, we're going to go to our second presentation of the morning. The title is Hospital Dental Hygienists, Essential Members of the Hospital Care Team. And Cindy Stahl and your group, take it away.
Well, good morning.
Morning.
We're actually trying to figure out how to use OHIP in the hospital. So stay tuned for that.
Yes.
Yeah.
Let's get everybody talking. I love it.
Yeah. So we're so excited to be here today to share our experiences in establishing a dental hygiene consult service with all of you at the University of Minnesota. And I really want to thank Nancy for the invitation to speak. I am Cindy Stahl. I am the director of the dental hygiene program, and I have here with me Keely Flavin and Mercedes Vanda Willie, and they are our two hospital hygienists. Next slide. So here are our objectives for you. I won't read them to you, but basically we hope that you all will go away with a better understanding of and an excitement for the role of a hospital dental hygienist on the hospital care team. I'd like to begin with a story that illustrates the impact that a dental hygienist can have on the outcomes of hospitalized patients. So in 2020, I was at the hospital precepting dental hygiene students during interprofessional rounds with both medical and pharmacy students. The attending physician requested a dental hygiene consultation for a 62-year-old male who we will call Doug. Doug had a past medical history of cirrhosis, and at the time we saw him, he was awaiting a liver transplant. This is the timeline of events leading up to the dental hygiene consultation. So initially, he was admitted to the hospital for hepatic encephalopathy, which is when a patient experiences mental confusion related to severe liver disease. He was given some antibiotics and improved a little bit. So 3 days later, he was discharged. On day 26, he started his liver transplant workup. And on day 59, though, Doug had a visit with his primary care physician where his family reported to the doctor that Doug was having some confusion and it seemed to be increasing. So by day 67, his confusion had worsened enough that they had some neurological testing, which then found profound impairment. This was potentially limiting his ability for transplantation as there was concern for this rapid decline without any clear source of etiology. It was unclear if even a liver transplant would improve the confusion because there was concern that it was not hepatology related. And in fact, the neuropsychology team diagnosed Doug as having dementia. By day 68, Doug had experienced 3 months of confusion and was admitted to the hospital again. Day 69 was the day that the two dental hygiene students and I saw Doug. And upon oral inspection, we found that there were multiple bombed out teeth. So I recommended that the medical team consult with the general practice residency dentist due to my concern for periapical infections. And in fact, a CT scan did show multiple abscesses, so the medical team immediately started some antibiotics. And within a few days, Doug's mentation improved. He was discharged. So during the time between day 72 and day 133, Doug started treatment in our dental clinics for all of these dental issues. On day 133, Doug underwent more neuropsychology testing, which showed no neurological contraindications for transplant at this time. So I think this case really just demonstrates the importance of having an oral health expert on a hospital team. Medical teams are not really used to looking in the mouths. It's not part of their routine. But I want to emphasize that Doug is just one of many cases whose unrecognized, undiagnosed oral pathology has impacted their overall health and well-being. Next slide. So liver disease, as in Doug's case, is just one of several systemic conditions that is impacted by oral pathology. And these studies here on this slide are just a sampling of the research that shows this impact that oral health has on systemic health. And I want to point out that there have been a number of studies that have shown the impact that a focus on oral health during hospitalization has had on patient outcomes. Next slide. The mouth is, in fact, the second largest microbiome in the body, with multiple surface types, each colonized with hundreds of unique species of bacteria, viruses, fungi, protozoa. And some of these commensals are significantly virulent, and they play a role in the initiation or progression of systemic pathology. And you may recognize, as you look at this slide, that most of the pathogens that affect systemic conditions are also periodontal pathogens. Next slide. We know that without the daily mechanical disruption of the biofilm, this oral microbiome shifts to more pathogenic species. These pathogens trigger the host immune response, increasing those inflammatory markers throughout the body. And for patients who are immunocompromised, such as hospital patients, this inflammatory response to these bacteria can regulate the severity and the magnitude of systemic disease. Next slide. We also know that, unfortunately, oral health deteriorates during hospitalization, and this is for a variety of reasons. It could be medication related. It could be due to the compromised immune systems of patients, or simply just a lack of attention to oral health care. Within 48 hours of hospitalization, if there is no oral health care, the oral microbiome can change from gram-positive streptococci to gram-negative pathogens that favor that systemic inflammation. In general, oral health care is not prioritized during hospital stays. For some patients, the only oral care they receive is swabbing with antimicrobials such as chlorhexidine gluconate. But this is ineffective, and it actually has been shown by recent research to be associated with increased mortality in ventilated patients. Additionally, many hospitalized patients experience severe dry mouth because they may be NPO, and this can lead to sores and ulcerations in the mouth. It leads to candidiasis and other issues within the mouth. In addition to the pathogens being able to be spread throughout the body through the circulatory system, these pathogens can also lead to aspiration of these pathogens into the lungs. So the respiratory pathogens that are found in the lungs are also found in the mouth. As these oral pathogens are aspirated, they promote inflammation in the lungs. So some of the respiratory diseases that are associated with these periodontal pathogens include pneumonia, COPD, and cystic fibrosis. Next slide. So poor oral health during hospitalization is associated with an increase in hospital-acquired infections, most notably hospital-acquired pneumonia, poor nutrition, increased costs of care, longer hospital stays, and poor quality of life, which eventually impacts the patient's healing. Patients who are most at risk for adverse consequences due to poor oral health are those who have experienced lengthy illnesses or may lack access to dental care even prior to hospitalization. And this impacts their ability to maintain oral health even before they are hospitalized. But there's also medical conditions that put patients at risk for systemic complications. And these include those who have experienced stroke, patients who have dysphagia, are undergoing cancer treatment, patients who are immunocompromised, or those who may be ventilated. Next slide. So there's this gap. While research clearly shows the importance of oral health in hospitalized patients, nationally, only 30% of hospitalized patients receive oral care. And we see this at the University of Minnesota. While there is a standing order for oral care in place, it generally isn't followed. And this is because nurses are busy and the oral care falls to the bottom of their list of to-dos. But I really think it boils down to the lack of training that physicians and nurses receive on the mouth. Next slide. So to us, it's clear that dental hygienists are the missing link in the hospital. Although it's not common practice for hospitals to employ dental hygienists, there are a handful of integrated models around the country. In each of these models, they're a little bit different, so hygienists perform different functions, but we are aware of hygienists who are in emergency departments, some who are in the ICU. And out in Oregon, there's several hygienists who are placed in small rural hospitals. And in these models, patients, upon admission, every patient receives an oral health care assessment and set up an oral health care plan with a dental hygienist. For us, we've adopted our own model and we call it a dental hygiene consult service line, similar to other service lines in the hospital. And so to look at the timeline of events here, this idea started back in 2015 when I wanted my students to expand their view of the role of a dental hygienist in patients' overall health. So I identified an oral health champion among medical school faculty who also wanted his med students to learn a little bit more about the mouth. So in 2016, we started a pilot interprofessional rounding experience for students, and actually Keely was one of those students who volunteered for this first pilot. And so the dental hygiene students joined third-year med students on their hospital rounds. And it was very successful. So from 2016 to 2018, we continued the rotation where the dental hygiene students rounded 1/2 day per week. And in this model, it evolved to where dental hygiene students would teach the med students how to perform oral exams, and med students would also teach dental hygiene students a little bit more about their patients' hospitalized conditions. So patients that were identified as having some oral health concerns were seen by the dental hygiene team. So in 2019, we expanded it a little further. We had new medical faculty oral health champions. We expanded the students' rotation to 2 teams and for 1-week rotations. We placed the dental hygiene students in the dialysis center to learn more about the role of oral health in end-stage renal disease. And we really did increase the collaborative care that we provided the patients. So this made me realize that we needed a hygienist in the hospital. So in 2019, I applied for a grant at the University of Minnesota, and we piloted what we called the dental hygiene consult service. So medical providers would consult with us when they had patients with oral concerns. Next slide. So no hospital is going to hire any provider, let alone a hygienist, without knowing the benefit, both financially and in terms of patient outcomes. So in 2019, I applied for a small University of Minnesota grant to pay for a dental hygienist in the hospital, just part-time, 20 hours a week. So Keely and I sort of divided this up this time, each covering about 10 hours a week. And you may remember that this is about when COVID hit. So it really did hinder our ability to be in the hospital, but even so, we all knew, the dental hygienists and the medical providers knew that this was a model that could work. So in 2020, I applied for and received a grant from Delta Dental Foundation of Minnesota. And this is a 2-year grant to pay for a full-time hygienist in the hospital. And it also pays for some equipment and oral care supplies for patients. And Mercedes is this hygienist that we hired. She started September 1st. And so her role in the hospital, along with Keely, and we'll talk about that in a little bit, is to provide oral assessments for patients on consultation from the medical providers, develop oral care plans, triage patients in collaboration with the GPR dentists, connect patients with community dentists for those who don't have a dental home, and then to serve as preceptors for the dental hygiene and medical students. So Mercedes is there 4 days a week, and Keely is there 1 day a week, and Keely serves as that preceptor for the students. So for this 2-year pilot, we have 3 aims, and they are to explore the feasibility of a hospital dental hygiene consult service, to explore the impact of the collaboration between dental hygiene and medicine on the oral and systemic health outcomes of these patients, and to explore the feasibility of tracking the impact of dental hygiene consult service on the number of non-ventilator hospital-acquired pneumonia cases. And with that, I'm going to hand it off to Mercedes, who will talk about the essential components for a successful dental hygiene consult service line.
Yeah, thank you, Cindy. So before a consult service can even be started, a few things are kind of needed to be put in place for that. So the first being a collaborative practice agreement with a dentist who is on board and really supportive of our efforts. Ideally, you would want a dentist or dentists that can also be consulted to the hospital. And again, we are lucky to have access to the dental residents through the GPR program and clinic. As Cindy previously mentioned, securing funding is also necessary. EPIC is the electronic health record or EHR system used in the University of Minnesota hospitals, which at this time is not integrated within the EHR system used in the dental school. So IT support and access are needed in order for us to view and add documentation to a patient's medical record. Again, since hygienists are not widely recognized as members of the hospital care team, IT and hospital management must also credential hygienists in EPIC and allow us to access the hospitals and treat patients. It's important for a dental hygienist to understand their scope of practice, as we may be responsible for kind of informing and guiding other providers in the hospital on what we can and cannot do under that scope, especially in a medical setting. We also must comply with the parameters that we've established in the collaborative practice agreement with the dentist. And then finally, continuous training and collaboration are needed by all involved to integrate hygienists into the hospital. Next slide. So in order to set a hygienist up for success in the hospital, a few essential items are necessary. We use disposable mouth mirrors to complete intraoral assessments. A headlamp or loops are used for adequate lighting. Hospital beds don't have the overhead lighting that dental professionals are used to. Laptop computer with some sort of EHR and imaging software for documentation and image capturing. A rolling cart to store and transport these supplies within the hospital. If radiology devices are being used, the cart must also have locking capabilities. And then finally, patient oral hygiene products such as toothbrushes, toothpaste, interdental adjuncts, mouth rinses, and denture products to provide to our patients during their stay. Being able to incorporate diagnostic imaging for intra and extraoral findings has been helpful, and these images can be stored in a patient's electronic health record for the collaborating dentist to view. Our hygiene consult service recently acquired a handheld X-ray unit to take intraoral radiographs when indicated, and then we also have an intraoral camera pictured here. Slide. So here's what we as hygienists are doing for our patients in the hospital. Our oral assessments include both a visual and tactile component to assess for signs of hard and soft tissue pain, facial and lymph swelling, the dentition, and then the mucosal surfaces from the lips all the way to the oropharynx. So in combination with imaging, we can evaluate and determine whether oral concerns can be managed with an oral care plan, or if a consult to the collaborating dentist is indicated. Our assessments also allow us to monitor a patient's health status over the duration of their stay, and then that allows us to provide follow-up assessments and care as well. We're also able to educate other providers, the patient, and then the patient's family and caretakers about how to care for their oral health and associated systemic risks. And we can do that by developing individualized oral care plans for these patients. And part of this assessment includes determining the patient's independence level. So ideally, we would want patients to be able to complete their own oral care. However, that's not always the case. So our role also involves supporting the nursing staff if a patient is unable to do this on their own. As Cindy mentioned, we also promote community outreach by connecting patients with dentists in the community and helping, hopefully, to eliminate some of the dental access barriers that patients may face. So we do this by providing patients with contact cards containing the School of Dentistry information for patients with no dental home. And then finally, we triage oral and dental concerns. So after we review the consult order placed by the medical provider and complete our assessment, we can collaborate with the dental resident team who can prescribe further imaging, do further examinations, diagnose, and treatment plan. So for patients, with sepsis with an unclear source or dental pain, this communication can really shorten the time to diagnosis, and then arrangements can be made for patients to be seen either inpatient or outpatient. And then we're able to document each encounter with our findings, the oral care plan, the services we provided, and then the recommendations for dental or dental hygiene follow-up if necessary. And this is all completed right in the patient's EHR and Epic. All right, so speaking of collaborating with other providers, who's ordering these consults? We've found that our reach is really growing in the hospital. So here we have listed some of the successful collaborations that we've had, and then where we would like to continue to work and grow. So speech language pathology in particular has been great because they're pretty aware of the role that oral pathogens play for patients who have an aspiration risk. Many times these providers and providers from all of these specialties will note patients with poor dentitions or oral health status. And then that's when we get consulted or advised that, we are there to help manage that patient. Social work has been able to assist with community dentist referrals and has been extremely helpful in oral care plan implementation for transitional care. And then psychiatry has been a more recent unit that we've been consulted to. These patients are often ambulatory and may not have some of the other systemic risk factors that we've mentioned, but oral care is often overlooked, and these patients can be in this unit for extended stays. They can be inpatient for months at a time and even up to a year. So prevention is obviously key for those patients to maintain both their oral and systemic health. So through collaboration with members of the medical team, here we have listed some common reasons and conditions for a dental hygiene consult. So common situations that we're consulted for would include sepsis with an unclear source and hepatic encephalopathy, which can be identified through triaging if oral or dental pain are present. Additionally, we have been consults are helpful for mitigating hospital-acquired infections and poor outcome risks for patients with dysphagia, those who are oxygen dependent and immunocompromised. And then finally, we may be consulted for managing oral care in patients with mucositis from chemotherapy, head and neck radiation, pre and post transplant evaluations, and those patients who are intubated. So we've demonstrated the link between poor oral health and disease, but oral health is even more important when we're looking at hospitalized patients with acute conditions. So the goal of completing routine oral care would be to prevent hospital-acquired infections and improve patient outcomes, which ultimately reduces the length of stay for the patient and the cost of hospital care. So non-ventilator hospital-acquired pneumonia, or NVHAP, has significant impacts on hospitalized patients. So obviously we want to do what we can to mitigate the risks of complications of hospital-acquired infections, again, ultimately reducing the patient's hospital stay and cost of care. So looking at the 3 pillars of aspiration pneumonia that speech-language pathology uses to determine pneumonia risk, oral care and environment are really the essential piece that dental hygienists can manage and improve. So basically, hospital-acquired infections, or pneumonia in particular, is multifactorial and requires prevention using a multidisciplinary approach. So with this current pilot project, we're really aiming to gather both process and outcome measures to justify the need for a dental hygienist to be on the hospital care team. For this first full year of a full-time service line, we're looking at process measures, several of which we have listed here. And this data will lay the groundwork for our outcome measures and help us identify the need for a hygienist in the hospital as we look at what the typical oral status is of these patients. So from there, we plan to look at how our services have impacted cases of NVHAP for those who have received these oral care plans compared to those who have not. So we're really looking to see if there are changes in the time to diagnose, the patient's length of stay, and readmission rates. We're also using a validated tool to assess oral health status. We're really interested to see how the oral health status of a patient changes after implementation of these care plans. And then this data will hopefully demonstrate the value of a hygienist and their services within a hospital. So we're about 4 months into this 2-year grant. Since September, we've seen nearly 100 patients in the hospital. We've found that the primary reasons for consultation are aspiration and pneumonia risk, triaging oral pain, bacteremia of an unclear source, and that usually ties in with poor dentition. More physicians are realizing the systemic impact of poor oral health on systemic health, but they may lack the knowledge of whether there are signs of active infection that could be altering the patient's course of stay. So it's really been encouraging to see an increase in these hygiene consults coming in. Of the patients that we've seen since September, nearly half have required further evaluation or imaging, which is really solidifying how prevalent poor oral health is in the hospital and what a risk it's posing to our patients. Some of the most common reasons requiring these further assessments have been for broken teeth, caries, concerns for abscesses that could be local or contributing to systemic infections, soft tissue pathology such as necrosis and cysts, and then patients who are pre-surgical clearance. So with that, I will hand it over to my colleague Keely.
Thanks, Mercedes. So first, I'd like to start by sharing another example of just how the presence of our service line and basically everything Mercedes just touched on has been integral in a specific patient case that we encountered just a couple weeks ago or a few weeks ago. So just this November, a 57-year-old patient was admitted. They have a history of recent kidney and liver transplant. They were admitted to the hospital for leukocytosis, anemia, blurred vision, and ultimately they were found to have elevated liver enzymes, which is a concern for organ rejection. About 5 days into treating this patient, the medical team noticed swelling around their eye and chin. And so they were started on antibiotics for cellulitis. On day 6, the patient started endorsing pain when chewing, and now their labs were concerning for sepsis. They continued on the course of vancomycin, and the medical team still considered them to be improving, and they were ready to discharge by day 8. By day 8 and 9, however, their chin started to appear worse. It was increased in swelling, more pain, and ENT was consulted due to now intraoral swelling and drainage as well. And so now they had a concern for a mental abscess that was draining into their mouth. Infectious disease team consulted the dental hygienist due to the poor oral status that they observed when they noticed that intraoral swelling. So ENT incised and drained that mental abscess, and then I went to go see the patient for an oral assessment. She did in fact have very poor dentition. There were multiple root tips, heavy calculus, and areas of multiple draining fistulas, broken teeth, that really I was concerned for sites of local infection that could be impacting their systemic outcomes. So I advised that a dental consult be placed and a dental CT be taken to further evaluate and diagnose this patient. When they took the dental CT, they did note multiple dental abscesses, and it resulted in inpatient extraction of 11 teeth due to the potential sources of infection that they were posing for this patient over the course of their hospital stay. So the patient was discharged on day 14, and since then, their white blood cell counts have been improving, and also their liver labs, particularly an enzyme that we see in high levels of not only liver organ failure, but also in dental disease, such as periodontitis and caries. So this case really proves how dental hygienists were an essential key for not only helping determine a potential source and an infection that was altering her course of hospitalization, also advocating for the patient, but it also got us thinking about maybe ways that we could even improve. You know, what if we saw this patient on admission? We could have maybe saved a lot of time and even further decreased that time to diagnosis. So that brings us to talking about some of the facilitators and barriers that we've been reflecting on as we've spent more time in the hospital thus far. Having this increased time in the hospital has brought to light what factors have really been integral for our success of our service line, and what barriers that we have encountered and kind of changed and worked on solutions for, and what barriers we are still facing as we think about our goals moving forward. So let's start with talking about what helps our success, our facilitators. We could not have our service line without groups of people who believe in us. This includes that collaborating dentist that we have in the GPR clinic, and also those medical champions that we mentioned. So this is the team of medical providers, the doctors or nurses, nurse practitioners and specialists that really believe in us. They believe in oral health being integral to overall health, and they've really been instrumental in advocating for our service and marketing our service line, which has increased utilization and which really ultimately benefits the patient. Other support that we have facilitating our service is support from the School of Dentistry. So leadership believing in us, believing in these initiatives and their importance, allow faculty time to be utilized and allocated to the hospital. And then finally, as we've mentioned, none of this would be possible without funding. So the Delta Dental Grant really is the reason why we're still in the hospital and able to even expand our services and offerings. Another big facilitator that we've learned and tried to adopt is that interprofessional mindset of all the healthcare team members is really a big facilitator to success, not only of our service line, but also for the overall health and treatment of the patient. It takes a team of specialists to care and provide the highest quality of care to hospitalized patients. So we see success when clinicians can adopt this interprofessional mindset. They understand the roles and responsibilities of the specialty consult lines that they can lean on. And when they understand and recognize dental hygiene as being part of their, their branches that they can utilize, that's when we see that interprofessional support, and that's when we see, success of our service line. And while we are getting close to being recognized as those essential members of the hospital care team, we have encountered barriers along the way. We have recognized that there is a barrier of people just forgetting about us. Dental hygienists are not really part of medical teams normally. We're not normally seen in hospital. And this really stems from the lack of that oral health training that medical providers receive in school, receive in training. And so while they might be aware of the connection of oral systemic health, they're not really trained to recognize pertinent oral health conditions that could be impacting or could be an active infection, and do not have enough knowledge about hygienists in non-traditional settings to know when to consult us. So in an effort to combat this barrier, we brainstormed ways to automate consult orders rather than relying on medical teams to remember us. And we do this through a kind of an automated checklist called order sets. So we've identified patient conditions that would really require an oral health assessment, like we've discussed earlier with aspiration pneumonia, endocarditis, so that we can see these patients earlier, and it wouldn't have to be them consulting us. It would just be automatically placed in their order sets. Another really key piece is that education piece. So Dr. Stahl mentioned our interprofessional rotation that not only helps educate the medical students and residents, but educating the medical staff like nursing and our specialists, and just having that increased visibility and being able to share success stories like we have been able to today helps educate providers on the importance of dental hygiene. Another barrier that we've encountered is how medical and dental systems are really not integrated. Many of the systems and procedures that we would like to use in the hospital are just currently not supported because medical facility does not have the infrastructure to support the dental care that we would like to provide. And pharmacy does not stock the oral health care supplies that we would like to utilize, such as fluoride varnishes, fluoride trays, or even silver diamine fluoride. And a way to overcome this is to use our outcome data that Mercedes was talking about to really highlight and prove the feasibility of having a dental hygienist in the hospital, but also those financial benefits. What money are we saving the hospital by catching these conditions and impact early, so that we can reduce cost and reduce length of stay, justifying a dental hygienist and justifying those integrative efforts. Related to this barrier is an integrated system is kind of some workarounds and how we've had to be creative with how we want to achieve our goals in the hospital. So for example, we have this portable x-ray unit. We would like to take x-rays and have them uploaded into the patient's healthcare record. Our Epic healthcare record we currently use does not support any dental imaging. So we've identified a workaround. We have our laptop, which we have a standalone dental imaging software on. We take an x-ray in kind of a blank patient chart. Then we use our smartphone with a secure Epic app on it, take a picture of the computer screen, and then upload it in the patient's chart. So is this ideal? No. Is it perfect? No, but it is a way that we can start to at least attempt to integrate some dental software with medical software. Finally,
I'm sorry, folks. We did just lose her, and it's not just me, right?
Thank you, Jeremy. Yeah, I was thinking, I hope it's not just me, or I hope it is just me.
Nancy, I was thinking the same thing.
Okay.
Yeah, same.
Well, so sorry about that.
I wonder if she even knows.
Yeah, she probably doesn't. Dr. Stahl, thank you to you and Mercedes and Keely. We'd love to have you come back for another opportunity. And I saw the comment in the chat about you at some point you'll be publishing. We'd love to hear that. We'd love to hear more.
and we'd love to be back maybe in a year when you're going to do this conference again and give you an update at that point. So we'll have a lot more data at that point. So
well, we love it. Thank you so much. We're going to move to our next presenter, but thank you so much. And one of the reasons we're meeting now is that I got a hold of you and I said, I got to make sure that you're free whenever we're going to do this.
I appreciate that.
Yeah. Thanks so much. And our next presenter is coming to us from California. I'm going to try not to hold it against you because of this. I don't know if you know, we've had quite a bit of snow. It's actually really nice here, but nice to meet you and welcome, Jeremy. And we'll let you take it from here.
Awesome. Well, just in my defense, I am from Canada originally and lived for a little while in Winnipeg. So Minnesota feels okay. It's not
all right. Thank you.
Foreign, right? And you'll hear a few of boots and a couple of A's probably make their way in. So
we'll feel right at home with you.
I will do my absolute best. So
thank you. Welcome.
So thank you so much, Nancy. And thank you very much, everybody, for giving me a few minutes on the day here. Definitely, even just that last conversation, I think some of the components that Mercedes was talking about of the lack of clinical knowledge and really just what do we do, and the epic pain points are there. So let me see if this will share appropriately. Is the presentation coming through okay? Thumbs up. No,
it is. Yes. Yeah.
Beautiful. All right. Did it go to a share mode, or sorry, is it only screen?
It didn't go to the slide presentation yet. It's it's got the slides on the left.
All right. Let me figure out to get the right screen going.
There we go.
Yay. All right. It's a good thing I didn't have any embarrassing notes or comments or don't trip. That's going to be good. All right, folks. Well, again, thank you so much. So my name's Jeremy. I lead for Pacific Dental Services, our strategic partnerships group, which includes our medical integration, basically all things insurance. We are in about 25 states now. Coming up early next year, we should be around 1,000 offices supported. But the really cool one, and why I'm so excited to be here, a few years ago, we actually opened 4 primary care medical locations to test in the real world, how do you integrate medical and dental together? Because there's so much great theory and so much knowledge in so many places, but trying to get medical docs and dental teams effectively talking and working together was, as we heard in the last group and kind of throughout the week, just challenging, right? And it's we know the need, we know why we're all excited. So that's, I won't spend much time on this, but just hitting back, I love this slide of just like the why. Everybody, I don't need to kind of say the rationale here, but just this is a data it's from Aetna on the left and UCCI, United Concordia on the right. But the ability to move and bend the curve on clinical outcomes and just total cost through oral health care, and making that part of a patient's unique experience it goes a really long way. So for us at PDS, where where we believe in our approach to this. And before I came onto the dental and oral health side of the world, my role was on the medical side, integrating pharmacy and pharmacists into clinical care teams. And we've been doing and working to do a lot of the same with oral health providers. Our whole philosophy and our approach towards patient wellness and overall outcomes is that the entire health system should be and is moving towards wrapping around the patient, right? Which means meeting the patient where they are and helping create sort of that holistic approach of just data and information, both at the patient's fingertips, but at each care provider's fingers. And the way that we've been doing that, and where I'll kind of get into the specifics in a moment or two here, but we've been seeing this as just building from the foundation up, right? This is not a PDS supported or even a DSO oriented initiative. We see this as foundational to the whole industry, and we need conferences like this and all kinds of other touch points to bring everyone along. Over the last 3-4 years, we've implemented, was finalized this past summer in all of our offices, a new instance of Epic, where we're their vanguard partner on fully integrated or a kind of a functional dental model. So I was smiling as Keely was saying of the pain of getting images, right? It doesn't support dental images in this way and that. I think we've got that, right? And we're sharing records with Kaisers, CVS's, Optums of the world in huge quantities now. But very, very much working to advance the research side of what's going on, shaping the industry consensus. We're so excited to be participating in and leading some of the work that was happening around medically necessary care. This past year, we joined an accountable care organization, so became a part of an ACO in Arizona, and are just really working with our 4 integrated locations to find ways to make this actually come to life in the real world. It really spans the gamut of kind of how we're approaching, from just patient education, as I mentioned, the critical nature, I'll touch on it again in a moment, of just what a difference an integrated EHR makes in the ability to drive results and outcomes. We're testing a lot of different models to see what actually sticks and what is most effective at creating outcomes. Our office in Union Village, this is one of the 4 that I mentioned, right? It's really one door into 3 locations. You've got a primary care medical, a general practice dentistry, and a pediatric dentistry. So shared waiting room across the board, whole body health messages every which way. If a patient comes in and is presenting with high blood pressure, or we actually do A1Cs at all of our Nevada dental locations now, just helping drive better awareness around diabetes, prediabetes, and the impact it can have on your oral well-being. But most recently, probably our biggest news was just this week. We announced a joint venture with Memorial Care here in Southern California. So we'll be building over the next 5 years at least 25 fully integrated locations, medical and dental, together. That's probably just the starting point that we're talking about as we look at the ability to create population health models, work with employer groups, insurance plans. But the out of the gate part, we're very excited. One of the key parts of this, and one of our big learnings in working with the accountable care organization, was the power of a single unified system, right? That ability to share data seamlessly between medical and dental. Memorial Care uses Epic as their EHR, and so do we now. And so just that ability to bring the 2 sides together to coordinate referrals, to coordinate health histories, and just really to see what's going on, is we're so excited to be moving in this direction, and think that much of the industry is heading this way as well. And we're said the word a whole lot this time, but we're excited. It can't wait to see this come together and roll out. So enough sort of the background, and please questions or comments. I'd love, just interrupt me if I keep going here. I wanted to chat a little bit about two structural areas, because we're learning a lot with just kind of the feet on the ground here of the infrastructure that needs to happen for oral health and whole body health to be integrated seamlessly. And then even just a couple of learnings just from the frontline experience. Again, Mercedes, Keely, love to hear just that patient case study and how that flowed through. But just a couple of points that we picked up, and then happy to discuss either on the call or anywhere further. The insurance companies, in some ways, are making really neat strides. Most all of the programs or the companies that have both medical and dental have some form of advanced benefits for patients with diabetes, cardiovascular disease, or really those other high-risk patients. But the structural stuff that we just need to see to really advance the ball in the US healthcare side is more and more of that openness towards the diagnostic coding and the health data. Until dental coding right now being just strictly procedural. You know, we were talking about this with a group the other day. We're pretty good at helping our patients understand the importance of treating periodontal disease, but at least a third probably still walk out the door being upset about, I just wanted my $59 cleaning, and you're trying to get me to do like this whole other thing, and some other dentist didn't say that's the case, or the insurance plan's requiring us to wait until it shows up on an x-ray when you're already into advanced bone loss. There's a lot there around just the fundamental policies and procedures. I think some of the value-based programs, if they're done right, can help move the needle on that front. But there's a lot we can do together with the insurance plans to advance the communication and the coordination sides of this. If you don't know her, Dr. Mary Lee Concello is Aetna's Chief Dental Officer. She's a phenomenal advocate of the oral kind of whole body health and mouth body connection. So we were very, very happy to be able to put an article in the compendium that talked to this. But we spend a moment or two just looking at our experience with the 4 offices that we built with the ACO. A couple of things I just wanted to highlight, and there's so many lessons along the way, but just to mention and touch base on here this morning. Oral health in the dental community, it is truly a very important access point, and it goes both directions. But we have consistently seen across multiple states, multiple offices, about a third of the patients sitting in our chair are not actively engaged on their medical relationships. Don't have a primary care, or if they do, it's usually the follow-up question, right? This is one of the things we learned is, do you have a primary care doctor? Of course I do, yes. Oh, when was the last time I saw them? Oh, 1974. Well, this is probably not an active relationship, and there might be something we can do there. But that entry point into the health system, whether it's A1C, identifying patients in a pre-diabetic stage, flu shots, not only is that great for population health, it works very well with Medicare Advantage plans and some of the incentives and the structures that they've got, especially if you can close the data link to that end. And as more and more kind of the Crests and the Colgates of the world are putting the integrated toothbrushes out, right, where you can see the data on how the patient's behaving, not only between medical visits, but between dental visits. There's some very exciting new work we can do managing high-risk populations. But that access point, I just had to double and triple down on that of knowing the value. I think in the oral health field, we still underestimate how unique and how much value we can bring to engaging patient populations and to finding and accessing folks that aren't otherwise taking care of themselves, or they may be generally healthy, but sticking in that preventative model, it goes a long way. Just a tactical thing on the fundamentals, right? We're really starting from the ground up. I think that assumption of knowledge, you can't have it any step of the way. Every time I think either me or my team have assumed that a dentist or a medical doctor or hygienist is comfortable having these conversations about why oral health matters, we've stubbed our toe probably along the way. So one of the tactical things we've done within our supported offices is started with our own teams, whether that's doing salivary diagnostics on our kind of as part of an office initiative, whether it's talking about the importance of diabetes or working through that education until it's owned by your front office, by your hygienist team, your DAs, and everyone across the board. It stays as a very awkward and unnatural conversation. Like, patients don't necessarily out of the gate yet make the connectivity between, why are you asking about whether I have diabetes or high blood pressure, or why are you taking my blood pressure, right? Those, unless you're comfortable with the why, it can kind of get awkward, for lack of a better way of saying it. But that repetitiveness across the board, right? We've also found the second piece of advice or kind of best practices that we've done would be around helping each office articulate and write down the clinical practice or their best clinical guidelines for when do we take blood pressure? Should be every time. When do we take, what do we do if it's in this certain range? Who's a patient who might be eligible for an A1C test or might benefit from the conversations that happen around that? What do I do in these scenarios? And have those guidelines laid out in advance goes such a long way to removing the pressure and candidly the thought or the judgment that comes into, am I comfortable having this conversation with the patient? But those fundamentals, when we've been having them, the case studies that have come out of identifying folks who were at extreme medical risk, or even just getting them engaged in their own preventative care, have been very, very exciting to see. Our plan is to continue to grow in that space through partnerships. The value of being a system fully on Epic now and able to kind of perform in a unified best practice way, we're looking forward to seeing what those results are as they come. I'm happy to I just talked a lot for 25 minutes on this. I live in a world where we're trying all kinds of new stuff. Some of it's working, some of it's not, but trying to move this from research and into pilots and to scale is a very, very cool place to be. And so that's why I'm very grateful for platforms like this, Nancy, for the way you've been pulling this group together. There's a lot going on. I know Minnesota is a very active state as well in this space, and so it's very, very fortunate and very, very happy to see it coming this way.
Well, thank you. We do have a question for you if you have time.
Please.
Yeah. So from your experience, do you have advice for how dental and pharmacy can implement collaboration for the bajillion people taking dry mouth causing medications?
Statistically, the formal number being bajillion, yes.
Yeah.
It's perfect. Here's probably where I'll start, which is, unless the clinicians are talking or the office teams are talking, there's no chance the patients are going to make the connection. So I would start, and my bias being from the dental operations side, is to say, if your hygienists, your DAs, and your docs aren't comfortable talking about the pros and the cons, the side effects, you're not going to get the patient to understand kind of what's going on or who they need to talk to. We've seen, as much as we've tried to systematize a lot of this, where it's most successful is when we've got either members of our office staff or clinicians reaching out to the local pharmacist or reaching out to the local doctor to put a face to the name. I wish there was a better systematic answer for this right now, because it's very hard to do that for a bajillion people.
Yeah.
But it is fundamentally a relationship and an awareness conversation right now.
Yeah, thank you for that. Your message about, starting with the fundamentals, starting with your own team, people being comfortable with the why. I think that's a really strong, really significant message for people. One other question on that is, let's see, no one doing warning labels on the pill bottles. Deb, if you want to talk about this, if you want to unmute, I'd love it. Otherwise I don't want to.
Yeah, and I don't want to take up too much time either.
It's
just that, Jenny has a great idea. And I just, since you worked with incorporating pharmacy, I didn't know if there were some pearls from that little things like that wouldn't be a huge lift, but might have a good impact.
Yeah, that's a great point. I heard, when you said that, Nancy, I heard no undoing warning labels, and that made my heart hurt a little bit. But yeah, no undoing warning.
Right. Yeah.
Makes much more sense. Yes.
Wonderful. Are you open to taking more questions or comments, Jeremy?
Of course, please.
Okay.
Now or after, or anytime.
Or I can, if you want to finish, I can stop.
Nope, I'm done.
Okay.
That was my last slide. I was hoping that we'd have a few minutes just to chat, or this is an environment that I love to be able to kind of pick brains.
Well, thank you so much. Yeah, does anyone, you can unmute, you could put something in the chat. I think for me, one of the things I'm really getting from your presentation as well is this, don't have any assumptions. The other thing is, it's like, we can do this. You're coming at it with this, we can do it. Dr. Oliphant, do you want to unmute and ask a question or comment?
Yes, please. First of all, your final slide here, I can't agree with you more. It's been my experience with some of the education we've been doing around HPV that we really just need a basic level of understanding around this stuff. And I don't mean basic in a bad way, right? Not at all. But I'm like, how do you get this role? Like, whose role to do all this education is it? Is it the system that owns all the dental practices in a state? Is it a public health department who insists on this happening? Like, where do you get these health education kinds of roles embedded, and where do they best belong? I mean, of course you can tell I want them everywhere. When you said dry mouth, I was like, oh, and I haven't even thought of that now. I got a new idea.
Yeah.
Thank you for that.
No, my bias is exactly where you said, is everywhere, a little bit everywhere, right? It's got to be more CEs, more in the dental schools. Our initiative, I guess, kind of our bias is we're working a lot with the dental and medical schools. Our founder's on the board of the Harvard Medical and Dental School, is just starting with the next generation. They have to understand this out of the gate. It takes a long time, but that clinical education, functionally in our world, the vast majority of healthcare is still done with an insurance plan, right, in network. So having their incentives and their structures aligned with this, right, like a value in dental in particular, right? Value-based plan cannot just be a euphemism for utilization management, right? We need to be properly diagnosing periodontal disease. We need to be just, it's grassroots. I wish I had a different answer right now. We've tried top down, we've done bottom up, we've done different components, but I think there's a role for every stakeholder in this. Not least of which the patient too, by the way. The more the patient is asking for this, and until they do, probably it's very difficult to force it anywhere else.
Well, and that's a good message for this group, because we're a coalition. And we've got some coalitions from other states on this call today. And that's how we work. You know, we're very diverse. And so when we come together like this and there's a message, then there are a lot of different people and different organizations hearing it, which I think furthers our work. So, well, I thank you. We cut your time today, and thank you for that, Jeremy. And I know we're done. We're past our 11 o'clock hour. Thank you so much. Thanks to all our presenters today. It's just been such a great week. I can't even say enough of how grateful I am to all of you. And so if you're not a member of the coalition, make sure you go on our homepage and join. Look to receive links to materials and resources from this week. And if there's anything you think the coalition should be doing or could be doing, or you have a great idea, or just kind of a little bit of an idea, just get a hold of me, because it's your coalition. And to those of you from outside of Minnesota, thank you for joining us this week. And I look forward to the next time we can be together. Thanks, everybody. Thanks, Jeremy. Yeah, and thanks for putting your email in the chat.
Yeah, please let me know.
Wonderful.
Thanks,
thank you.
Bye, guys.
Bye. Bye. Good to see you.